just looking at its effect on SHBG, that is going to decrease your free androgens circulating, and SHBG also binds to the androgen receptor in the scalp. Our friend Ben Barros likes to talk about this as well. So it has a lot of a regulatory mechanism, whether it is bound or not bound to an estrogen.
So I've heard you talk about this before, women, birth control and the different, I think there's 4 generations now of oral contraceptives. So some women, I guess girls at this point, whenever they start having, irregular periods or acne or thinning hair, they get put on an oral contraceptive, and that seems to solve a lot of problems. And they're not always a terrible intervention. But what are some of the underlying reasons for that? It's always fun to dive a little bit deeper and say, okay, well, this has these effects, but why is that? And talking about why things may be different when you have different types of estrogens and then different types of progestins as well.
Mm-hmm. So this is one of the conversations that I particularly love. Sometimes I joke and I say that I wish that patients were as picky about their compound selection for their synthetic estrogen and their synthetic progestin as many men are for their compound selection of their synthetic androgen. So just like synthetic androgens, the fitness community loves, and we actually love talking about different pharmacodynamic effects, interactions with aromatase, interactions with glucocorticoid receptors. Does this compound aromatize? Is its aromatized product active? We love talking about the same exact thing with oral contraceptives. So there's combined oral contraceptives, which have a synthetic estrogen and a synthetic progestogen, known as synthetic progestins. And we'll put a chart up here too. And someone can, this is just the most common synthetic progestins. There's only 2 synthetic estrogens that I know of, ethinyl estradiol, and then there's a brand new one that is potentially useful as well. But the synthetic estrogen and progestin itself, they have a common theme. Both of them tend to increase SHBG pretty high. And the stronger the estrogen, the more of an increase in both SHBG and platelets you get. That's also going to affect blood clot risk. This podcast is not about oral contraceptives, but just looking at its effect on the SHBG, that is going to decrease your free androgens circulating, and SHBG also binds to the androgen receptor in the scalp. Our friend Ben Barros likes to talk about this as well. So it has a lot of a regulatory mechanism, whether it is bound or not bound to an estrogen. So you think, well, higher SHBG is always better, but that is not necessarily the case. It usually is for hair, but you have to take into account all the other systems of the body. If we didn't have to do that, then hair loss prevention would be much more simple.
Yeah, just give everyone ethinyl estradiol and we've solved hair loss.
Yeah.
But no, I think oral contraceptives are really interesting, and there's a number of different things that have been looked at here. And I don't have the studies pulled up because this isn't necessarily an oral contraceptive podcast, but some of the things you can see, compared to certain times of the menstrual cycle, you may have better object recognition if you're on an oral contraceptive.
Yep. And
in terms of 3D image rotation, which is stereotypically thought of as a more male dominant skill, more engineers that are male in that field. When you see women who are taking contraceptives, you'll see an improvement in that sort of ability to manipulate a 3D object in space. And I think that's really interesting. It probably has to do with the androgenicity of the progestin that they're using.
Yep.
So probably, I would suspect, just speculating, we're not going to see that with drospiridone, but we might see that with levonorgestrel because drospiridone is anti-androgenic.
Both bind the androgen receptor, and just because it binds the androgen receptor does not mean it activates it. So there's a competitive inhibitor, and then there's also allosteric inhibitors, which bind the receptor, but at a different spot that it's its normal binding spot. And synthetic progestins often do both in multiple systems. So again, we'll try to find that chart that shows its interaction with cortisol's binding globulin, kind of like SHBG, but for cortisol. And only bioidentical progesterone binds it, of course. And then also its interaction with the glucocorticoid receptor. And at some point, we'll just do another full podcast on oral contraceptives, or perhaps it will just be on synthetic hormones in general. That would be fun.
Yeah, I was going to suggest the same thing. I mean, how to design your best oral contraceptive.